Hi, everyone, again. I'm Azim Lateeb from New York, and welcome to our first session of TIO 2026. And this session is on whether transcatheter technology can approach native valve physiology. I think in the world of lifetime management and our patients becoming younger and younger, this has really become a very important area, is how can we design valves that will be as good as our native valves. So it's really my pleasure to do this session with our distinguished panelist. Greg Fontana needs no introduction. He's a close friend and colleague, and really one of the people I really look up to in the field of structural. He's a surgeon that is active in both the field of surgery and structural and really has amazing insights. So, Greg, thank you for joining us from Los Robles Hospital. We really glad to have you here. Our
Thank you,
second
Azim.
panelist, our second panelist, Andrea Scotti from Montefiore, New York. And the three of us together over the next 45 minutes really want to take you into this new technology and discuss how we can potentially continue to push the boundaries of TAVR in sort of what we do with that first valve that we implant. But before we start Greg's presentation, we wanted to open with a poll. And so if we'll bring up the poll for the audience, and poll number one is, when defining hemodynamic success after TAVR in a younger patient, which metric matters most to you? Is it A, mean gradient less than 10? Is it an EOA greater than 1.5 centimeters squared? Is it the absence of patient prosthesis mismatch? Or is it LV mass regression at 6 to 12 months? So, four very different factors that we want you to think about. While the audience answers that, Greg, why don't you start setting the scene for us about this new technology?
Great. Thank you, Azim. Very, very pleased and honored to have been invited to join this fantastic meeting. It's a great schedule, great speakers, as you've mentioned. And I'm looking forward to starting the session here with a discussion around the biomimetic TAVR design physiology. Let's see here. Looking for my green button. I don't see it, so I might have to have some assistance, you guys, in the control room. I don't have any present or have had the last 24 months any financial relationships with the ineligible companies. Next. So, is this a normal valve? You know, and we've learned, I think, over the years in surgery that all the valves that we've implanted have really not been anything like a normal valve, with the exception perhaps of the Ross procedure, where we're trying to achieve the lowest possible gradients. I mean, gradients of 1 to 2. And we've grown to accept with surgical valves gradients maybe over 10 in many cases, and most post-TAVR valves mean gradients between 8 and 12. You know, once in a while we see better than that. Sometimes we see worse, but that's basically what we've been dealing with for the last nearly 20 years now. So as TAVR becomes lifetime therapy, clearly valve physiology is increasingly important. Next slide. So native physiology is quite interesting. I don't think we studied it enough in the context of TAVR, but now we're refocusing. Clearly that in native valve physiology, there's central laminar flow with minimal resistance to forward flow. There's an extremely efficient hydraulic structure. Flow accelerates through the valve and the pressure falls. And as flow expands in the aorta, pressure partially recovers. The gradient is a measurement of physiology, and physiology is energy loss. So we're going to try to just briefly discuss some emerging concepts of the way we should probably expand the way we think about the performance of our valves. So nature designed an aortic valve for minimal energy loss. Next slide. So gradient alone does not define valve performance. If we look at the impact of aortic flow in laminar versus turbulent flow, in laminar flow, there's efficient flow with reduced afterload. There's restoration of laminar flow that may impact the workload of the left ventricle. And laminar flow may impact the durability of the valve and also the rate in which the valve might degenerate. In turbulent flow, inefficient flow creates energy loss. There's inflammatory response to this to turbulence as well as thrombosis, and subsequently atherosclerosis. This also may possibly disturb coronary flow. We're trying to understand if this is clinically relevant or not. But there's also possible impact on heart outcomes like stroke. Next. So hemodynamics and LV workload. So we know that residual valve obstruction increases LV wall stress. There's an increase in myocardial oxygen demand, increase in cardiac work, and reduce LV reverse remodeling if we don't bring the gradient down to near normal. The ventricle feels every millimeter of gradient, and this has been well established. Next. So what do we need? TAVR has clearly transformed treatment of aortic stenosis. And as we move toward lifetime therapy, the goal is no longer simply a valve replacement. The goal needs to be restoration of normal valve physiology. The next generation valve platforms need to be designed with this principle in mind. Next. So, Duraver is a new class of TAVR. We're going to introduce the concept of biomimetic valves. So the valve is very novel in its design. There's a single piece of bovine pericardial tissue shaped into a unique native leaflet contour to mimic a healthy valve. This is demonstrated by hemodynamic valve performance on easy-to-use balloon expandable system. It's designed to restore physiologic laminar flow, and it's built for durability with tissue, shape, and flow. So overall, the idea is to start again from the beginning, come up with a valve that it looks as close and performs as close to native tissue as possible. Next. Here's an example comparison between a small Sapien valve, a small Duraver, and also a 26 millimeter Evolut Pro. So those would be similar in terms of valve selection for a small annulus. And you can see left to right the differences in the performance of Duraver versus the commercially available valves. There's less pinwheeling, there's less fluttering of the valve, and so performing more like a native aortic leaflet. Next. This is the valve. There's a single piece, as I mentioned, native shaped biomimetic leaflet design. It has an anti-calcification treatment called ADAPT. There is a PVL mitigating skirt. There are radio-opaque markers at the commissure alignment for commissure alignment. It is a short frame with open cell design, quite large open cells for coronary access. And it is a balloon expandable cobalt chromium stent frame. There are three sizes, small, medium, and large, which cover from 21 to 29 millimeter of CT aortic annulus area derived. Okay, next. And finally, there's a very unique, a new delivery system called the commissure. It does have active flexion integrated into the delivery system, and also active commissural alignment. There's a volume adjustable valve sizing for very specific expansion of the valve to the target diameter. And this all goes through a 14 French expandable sheath. On the right, you can see example of precise commissure alignment. There are three markers at the top of the commissures, and when this is placed in the cusp overlap position, very similar to what we've experienced in the past, see one dot to the right and two to the left, we know that we're very close, if not spot on, to commissure alignment with this balloon expandable valve. I think that's the end of my presentation, Azim.
Great, thanks, Greg. I think you really set the stage, and I can see people are watching, because a lot of the questions are, I can see people are intrigued about this new biomimetic design. So before we get into some of the discussion, let's get the results of the poll, because I'm interested to see what the audience thought. So I guess for majority of the audience, almost sort of 75%, it's either the mean gradient less than 10 or the absence of patient prosthesis mismatch. And then less were worried about EOA, maybe a few more moving from EOA to LV mass regression. I mean, that's something we should talk about. I mean, when you see this, Greg, are you surprised?
I don't know if I'm surprised per se. I I I think everybody looks at this mountain from a different position. It's the same mountain. We're just have a little different perspective around the sides. So, but I think increasingly, I would think that ppm should be probably conceptually the target. Everything else is sort of a surrogate for ppm. But I'm not surprised. I think this is probably a pretty normal distribution for today.
Yeah. But what about this? I mean, because you briefly mentioned it in the sense that, the more the gradient, if for every millimeter of gradient, the ventricle has to work harder, right? Um,
Right. Yeah.
so this, on the fourth one there, we mentioned LV mass regression. I mean, we've started to see some of that data from a partner, but we've not used that routinely as a secondary endpoint even. Do you think that's something important moving forward that we should be looking at?
Yes, I do. I think, unfortunately, though, it doesn't tell the whole story. We know that even patients who have fully relieved aortic stenosis and pressure loading of the ventricle may not have normalizing LV mass at the end of the day. Some people, as we see 6 months later, still have significant diastolic dysfunction related to LV mass not regressing. I think the whole process of hypertrophy, pathologic hypertrophy and regression is something that we don't fully understand. I've said before many times, I'm sure on the podium with you, Azim, that I think one of the things we're playing catch up with now is understanding the ventricle at the time of therapy. How many of them have fibrosis? How many have, let's say, we're overly enthusiastic hypertrophy relative to the gradient? So I think it's important. I think it's a great surrogate for relief of the pressure loading, but I don't think it's the whole story. And I think that's something we really need to focus on going forward. Maybe CMR, which is going to be a part of this study that we're doing with Antares, will look carefully at the pre and post-op, post-procedural laminar flow, number one, but also looking at ventricular muscle and how it behaves after fully or almost fully relieving the gradient.
Yeah, absolutely. I mean, we all see these patients, right, where we do their TAVRs or we do their valves, and they still have symptoms afterwards. And I think a lot of those symptoms are, like you said, related to this ongoing diastolic dysfunction because we've relieved the stenosis, but they still have usually hypertrophied ventricles. And I think whatever we can do, like you mentioned, decrease the work or load of these LVs may potentially have long-term benefits that we've just not studied very well before.
Probably the
There's
best
maybe
argument
one
for
question.
its best argument. Oh, sorry. I think it's maybe the best argument for some of the studies for moderate AS or early TAVR that we've looked at is, perhaps we are in some subgroups waiting too long to treat these patients. And if we just bundle everybody together as if they all have the same ventricular pathology, I would expect we would have unpredictable outcomes and some that benefit and some that don't. So I'm imagining in the future that we're going to be looking at these patients with moderate aortic stenosis earlier with imaging. Maybe we'll get to the point where we can do it with other non-CMR, easier technologies for maybe echo to basically pull the trigger at the right moment for that patient.
Yeah. Yeah, absolutely. I'm sure there are going to be AI technologies that help us try and understand this earlier. So maybe there are a couple of questions. Some of them we're going to address later. So I'm going to ask you in the audience just to wait because we're going to get to things like EOAs and mean gradients, and we're going to get to commissural alignment when Andrea shows us his case. There was just maybe one question, if you want to tackle this, Greg, was does this biomimetic design philosophy, how does this philosophy translate into any measurable hemodynamic advantages? Is it just a question of the design? Maybe just a very brief comment. You've seen so many valves over the years come and go, and some that are still here.
Yeah, I think what's been clear for many years now is that gradient is related to design. We start talking about supraannular valve having an advantage. However, we have an intraannular self-expanding valve that has very similar hemodynamics, even though the valve is intraannular, and has better hemodynamics than a sapien valve initially, and even at follow-up. So clearly, design matters, and Anteris has taken this a step further, and creating not just a valve that opens nearly completely, essentially all the real estate is available for EOA, but also in the shape of the leaflets, and it allows for such a low gradient that I think it's well, we'll see with time, but the early indications are we're seeing some of the lowest gradients ever, and certainly in the context of a balloon expandable valve, the lowest gradients ever.
Yeah, absolutely. And we'll show you some of that data in a moment. But I think we're going to move on to Andrea. Andrea, before you start your demonstration of a case, because we thought we introduced you to the technology, let's show you how we implant this in a patient and then some outcomes. But before that,
Just
we really want to understand what's important to you. So, in a young, low-risk patient undergoing their first TAVR, which of these factors weighs most heavily in your valve selection? Is it hemodynamic performance, or B, the pacemaker rate, C, commissural alignment, D, TAVI and TAVI feasibility? I know most of you want an E, which is all of the above, but we're going to make you choose one of these. So, Andrea, we'll come back to the results after Andrea's presentation. Why don't you take us through a case, Andrea, of a Duravar?
So it will be a pleasure now to show you how this Duravar is implanted. I will use a case that we did in Montefiore to explain you all the steps, and we will see how this valve is actually implanted. I have no disclosures. So I will introduce you the patient of today. This is a 66-year-old woman who came to us very symptomatic with shortness of breath, NYHA class 3, fatigued. Also, she had some episode of presyncope, non-obstructive CAD. You can see normal risk factors, diabetes, hypertension, some CKD with a GFR of 54, as you can see on the right. This was a low surgical risk patient. She adamantly refused surgery even after we offered this to her, so we proceeded with TAVR evaluation. And I will show you here now just briefly the EKG show the first degree AV block, slightly prolonged PR 206. And this is the echo that you can see at the bottom of this slide. You can see an hypertrophic ventricle. The valve was measured as having an area of 0.83 with an ingredient of 34. And as you can see on the right, mild, probably mild to moderate aortic regurgitation. Normal EF 60%. So next step was getting the CT scan, the CT TAVR. As you can see on the CT, we can already appreciate how this annulus is small. I have to say very small in this case. The area measured as 346 millimeters square with a perimeter of 67, with decent coronary height, femoral access, and of course it was a 3-leaflet aortic valve. Here, just more measurements for you to understand the anatomy. You can see the STJ was large enough, 27 millimeters the diameter. LVOT was in line with the annulus, so very small. And both coronaries were not at risk for both the height and also the space in front of the coronary. So the access was actually more than adequate, a great access, no significant peripheral artery disease, no tortuosity. So in this case, we decided to go right. And also you can see the angles that we will be using for this valve implantation, differently from other balloon expandable valves, especially for the Sapien, which is the one we commonly use. Here we also obtained the right-left cusp overlap view, and we will see this during the case, how we use it, because this is going to be needed for the commissural alignment. So this is just to introduce you the team. Azim was the first operator for this case. I have to mention we had also Edwino, our echocardiographer. This case was done under GA&T guidance. This was one of the first cases we did 3 years ago. So we really wanted to learn about this valve, and I'm glad we did it because I can show you something interesting about this valve later. And then also the rest of the team very important, our tech, anesthesiologists, and medical coordinator, as well as all the research team who made this possible. So we now jump into the case without wasting time. So before we play the video, just want to give you an idea of the setup of the case. So there was a TVP already placed in the right ventricle. You can see here. There is a pigtail here in the aortic valve. The valve was already crossed and the Safari small was placed in the ventricle. And also there is sentinel that we use for cerebral embolic protection. Now, you will have for the video the T on the right side of the screen, the floor on the left. So please follow me. I'll stop in every step of the procedure. This is step number 1. So we are going up with the ComaSure delivery system. The first thing I would like to highlight for this valve is that the valve is already mounted on the balloon. So there's no maneuver that we need to do in the descending aorta. We will just go and cross the arch. So this is what you will see us doing right now. And as Greg explained you earlier, there is an active flexing system, so we can actively flex the ComaSure delivery system so we can safely cross the arch and then cross the aortic valve. Of course, we were entangled with the pigtail, so we quickly repositioned it. And now we are ready to push forward and cross the aortic valve. Here, the aortic valve is crossed. Next step, same as with the Sapien, we unsheath the delivery system. This is what we are doing, keeping the valve in place, and we unsheath the delivery system up to this marker here. So I'm gonna stop now. I want you to look at some things that are very particular about this valve. So you can see, first of all, one radiopaque marker here where my mouse is. This is gonna be used to position the valve. So our aim is to place this on the annular plane, which is more or less here, if you use the pigtail to define the hinge point of the clasp. This is the frame of the valve. You can see here, you will see it better, some radiopaque markers. Here we are in a clasp overlap view. So in order to achieve perfect commissural alignment, we know that the right and the left coronary clasp are overlapped on the right side of this screen. So we want one commissure to go to the right. Okay, and we want 2 other commissures that we can see here, but you will see them better as soon as I play this video, to be in overlap on the left side of this screen. So it's a very fine maneuver that we are doing using the delivery system. And you can see here they are slowly moving until we see them in overlap right now. I'm gonna stop again. You can see here one above the other on the left, and the other one is not very well seen because we are seeing just the side of this marker, but that's where it is, on the right side of the screen, so can go towards the commissure between the right and the left coronary clasp. At this point, for this case, we went to the tricasp view, rapid pacing, same with as with the Sapien. And I'm gonna go back just a second. Again, we use this marker to position the valve, and then rapid pacing, and we expand the valve just by inflating the balloon. This is how the valve is implanted. At this point, you will see we will pull back the delivery system. In this case, since we have TE, we use TE to check the valve. You can see actually we have a good result, maybe some trivial PVL next to the mitral valve here. But in any case, our decision was to optimize the frame. And this frame optimization technique is actually like done by inflating again the delivery system with the same amount of volume. And this is what we will be doing soon. First, we will go on rapid pacing again. And here we are inflating the balloon. After this is done, then we can remove both delivery system and wire. And at this point, we cross the valve again with the pictel. Here we're showing you the invasive gradients. They're almost in complete overlap on the hemodynamic curves. And we will see also some gradients being traced now by our echocardiographer. I'll jump forward here. I can show you the valve, well aligned. The left main is right in the center of the new sinus. Here, an aortogram. No PDL. Valve is well expanded. We have excellent coronary flow. I'm gonna stop here just a second. Just of note, this was the earlier generation, is 25 millimeter high. Then this was a small valve. The new one that we're currently using in Paradigm is actually much shorter than this. It's just 20 millimeters. Here, just to show you the mean gradient we obtained for this case. It was 4 millimeters of mercury. At this point, we are satisfied with the implantation. We are already removing everything, as you can see on the left, sentinel out. Here we are still measuring, again, 3 millimeters of mercury. I just want to show you the last step of this procedure, because I think it's very unique, and that's why I'm glad we did T. You can see here how actually the valve is working. We have a very long coaptation line that you can see here on the leaflets. It's better appreciated by this video is moving. But this is one of the design features of the valve and the leaflets that is probably associated with this laminar flow that Greg was talking about and restoring a more physiologic flow across the aortic valve. So here just the access closure, we have beautiful closure, and the case is done. So I'm gonna stop here.
Right. Thanks, Andrea. That was fantastic. We're going to get into a lot of the discussion. There's a lot of questions coming through, and we'll get through a lot of them. I just maybe we'll address two, and I think because of time, I'll just go straight to my presentation, and we'll try and address the others afterwards. So, Andrea, there was a question maybe for you: is what made you or made us select a Duravar in this patient over another valve? Was there anything about the anatomy for Duravar compared to other valves? Yeah, we lost Andrea again.
Mike,
Yeah.
Can you hear me now?
Yes, we're
Okay.
down.
So yes, excellent. So yeah, that's a very smart question, and I'm gonna let everyone know what our discussion was about this patient, because this is a very young patient, a patient with also very small annulus. So we didn't want to give this patient a prosthesis patient mismatch. Her BSA was 1.8, and at the same time, we wanted to plan for a lifetime management. So what's the best way to do this? And that's why we wanted to offer this valve to this patient, because with this valve, we had excellent hemodynamics. I showed you during the case was 3-4 millimeters of mercury, but I can tell you even at discharge in 1 month and then on the yearly follow-up, this gradient remained very, very low. We could align the commissures, so we know that the commissures are not in front of the coronaries. And with this valve not being a very tall valve, we can also guarantee that this patient can undergo a valve-in-valve and maybe a valve-in-valve-in-valve in the future. So I think this was one of the reasons why we thought that this was a great option for our patients.
Right. And maybe a last very quick question, quick answer. How difficult is it to do the commercial alignment? What's the learning curve?
I think it's not difficult at all. It's just a fine maneuver. Once we are already, the beauty is that we don't need to go back into the descending and then cross the arch again or risk stroke for our patients. We just do our valve procedure as we used to do with any balloon expandable valve. Once we are there, we just align the commissures. Once we reach the optimal alignment, then we just deploy the valve. It's not something that will need any learning curve.
Okay, great. Thanks, Andrea. There's a lot of other questions I want to get to with you and Greg, but just for the sake of time, let's move on and we'll try and do some final discussion at the end. So let's have the results of the poll and see what the audience thought was important for them. So 40% thought commissural alignment was the most important. Another quarter thought hemodynamic performance, another quarter TAV and TAV, and very few were concerned about pacemaker rates. I guess, that's right. I guess with these newer technologies, we're seeing much lower pacemaker rates. So there were a lot of questions from the audience about, the data for this valve and how it compares to other valves. So let me take you through some of the data. Hopefully it will answer some of your questions, and then we'll come back and talk about and address some of your other questions that I see in the chat. So I'm going to be talking specifically about the 30-day outcomes that we have so much with this technology, and particularly this technology so far has been available in a small size, and so with that, we really got a good understanding of how it does in patients with small annuli. So this is where we are. The first patients were treated in the first in human study starting in 2022. That's when the first patient was started. So that's when this technology went into patients, and since then it's evolved rapidly. The company's been very good at making changes to improve the delivery system, as Andrea said, that shorten the valve height, change the balloon on the delivery system so it really ensures you have commissural alignment when you expand it, and then develop things like an expandable sheath. But with time, as you see, there's now been about 130 patients treated, majority in this Embark First in Human study. There's also been an early feasibility study in the United States and the EU, some compassionate use cases in valve, and most importantly, just a few weeks ago, Andrea treated the first patients in the Paradigm pivotal trial in the United States. You saw an example of the valve. Here's another example, and we're just showing you some of the anatomies we've treated. So we really haven't just, selected only easy patients. We've really tried this technology in really every challenging anatomy you can think about: patients with severe calcium, patients with LVOT calcification, and patients and bicuspid anatomies as well. And so far, we do have some published data. So this paper, where a number of us are co-authors, was published in Neurointervention, and it really shows the 30-day outcomes of this small Duravar in 100 patients with small annuli. By small annuli, the annuli area was 346 to 452, so slightly bigger than we saw in the SMART study. But when you look at the clinical outcomes, really great 30-day clinical outcomes, zero mortality, minimal vascular complications, 6% pacemaker rate, and really very low rates of moderate to severe PPM. When you look at the valve areas and the gradients, you see that the gradient dropped from 48 an average to 8.2, and has really stayed constant at 30 days and 1 year. When you look at the EOAs, also 2.2, which is really, impressive when you think about the fact that we're talking about a small valve. So single-digit gradients, EOAs close to 2 or higher, and a DVI of 0.6. So really fantastic outcomes in these patients, in these 100 patients that were treated in the first in human study. And this is just the beginning. Obviously, we need more data. The other interesting part was, because of MRI, that potentially we can start looking at what Dr. Fontana mentioned, which was, laminar flow, right? We know what normal flow should be with your normal valve. And we know that aortic stenosis creates turbulent flow. What we've been impressed with in some of the MRI data we're collecting is that when you look at DurAVR, you see very laminar flow. You look at sort of this red area, and you look at what a large red area there is of forward flow without that mosaic of turbulent flow. And really, this has been, for many of us, a new novel finding of this biomimetic valve that we really have not seen with other transcatheter heart valves. Another important part, and goes back again, tying it back to what Dr. Fontana said about every millimeter of gradient matters to the ventricle. And so the more the ventricle has to work and the more gradient you leave behind, the probably, potentially there could be less LV mass regression, right? And what we're seeing with DurAVR so far is really significant LV mass regression, which again is an important additional factor early on, that maybe this laminar flow is really doing what we think it is and is restoring more normal flow, that patients lose their LV mass, that can regress their LV mass. So I think that's been very reassuring and promising, particularly when we do see that there is data from the partner series that LV mass regression is really correlated with outcomes. And so patients who have less regression have worse outcomes. So in summary, this DurAVR appears to be a very unique design. It has this biomimetic single leaflet design that, with the hope of really mimicking the normal valve. The 30-day outcomes in the first 100 small annuli patients are very reassuring and promising, with no mortality and low pacemaker rates, and only a 3% moderate or severe PPM. Very favorable hemodynamics, again, small group of patients. The initial CMR data has also been very interesting for looking at how we can maybe potentially restore laminar flow, and that there's evidence of LV reverse remodeling. Obviously, we need more data. And to get more data, we now have commenced with the Paradigm clinical trial. This is a large, randomized, pivotal IDE trial to get approval for the DurAVR valve in the United States as well as globally. Patients will be randomized in a 1-to-1 fashion to DurAVR or to a commercially available valve. And so we enrolling 1,054 patients, all risk, will be randomized. They'll have CT. There'll be a sub-study with CT and MRI. The usual primary endpoint for TAVR is studied in 1 year, but all patients will be followed up for 10 years, so we'll have hemodynamic data out to 10 years. There's also a failed surgical valve-in-valve cohort, and then an FDA requirement is that we do another 446 patients after we've done the first cohort to continue to get more data in low-risk patients to really understand the valve. So this study that started enrollment will really give us very important responses to a lot of the questions that you are asking. So, and then maybe gives you a sense of where we are. Thank you. So Greg, I'm getting tons and tons of questions here from the audience. And so maybe there's one that I thought was really interesting that I wanted you to talk about. And really, someone was asking, what do we think the durability could be of a biomimetic valve versus a surgical bioprosthesis? And this physician is asking for in a 75-year-old patient today. When you have that discussion at your site about why a patient should enroll in this study, how do you address this question of durability?
That's a great question. I think, we've learned so many important lessons in the past of surgical valves with great initial hemodynamics and showed great promise that did not have the durability we expected. So clearly, we have some durability data that's out about 4 years now with this valve, small numbers. But I think a lot of the components that are essential to valve performance and durability have been incorporated here quite actively. Number one, which of course the gradient. Number two, the most common way most valves fail, tissue valves fail, pericardial valves have failed in terms of mechanical factors is probably related to attachment of the commissures. And since you have one continuous piece of pericardium, my expectation is that's going to add to durability. Obviously the thing we won't know for years to come is this anti-calcification treatment going to prevent aortic stenosis as we're seeing late in pericardial valves, both surgical and transcatheter. So I would say that there's been some incremental improvements in design, and still including the important factors that have helped your build in the past, and that we're optimistic this is going to be a step forward in terms of durability. But obviously, we can't overpromise in a case of a clinical trial. But that would be what I would say.
And I mean, is it a challenge? If you have a patient who's low surgical risk, say 68, what kind of discussion are you having with that patient to say you should be involved in a clinical study with this new technology, which, again, very unique design, very promising data from the 100 patients, and also a company that has making tissue. I don't know if many people know that. I mean, this company didn't start yesterday making tissue. They've been making tissue for, I think, 15, 20 years. So they really have a history of bovine tissue. But still, we have patients, right, who ask us, but hang on, why not just give me the commercial valve?
Well, I guess there's a step function there. First of all, we need to make sure that this is going to be a TAVR patient. When I'm talking to young patients about surgery versus TAVR, we all understand their apprehension for open heart surgery, even if it's done minimally invasively. And some patients just are not going to accept surgery. I always reinforce the fact that all this, the data we have to, heretofore has not included many patients under the age of 70 and certainly under 65 or 60, as we're seeing lots of implantations of TAVR valves these days. So once we decide we're going to take this position of TAVR, I think this particular technology offers potentially unique advantages over commercially available valves. And I would present it that way. Now, as we all have experienced, some people just don't want to be involved in clinical trials, and so we will proceed with a commercially available valve. But I would say that I would be very enthusiastic to present this opportunity to patients who are going to be a TAVR treatment for their aortic stenosis, and give them many of the reasons we've just discussed this morning as supportive evidence.
Okay. Correct. Andrea, last question for you before we move on. And again, maybe it's a short response. Some of our audience are asking, was there anything, what surprised you the most compared to your expectations about the procedure, either intra-procedure or post-procedurally, when you look at this biomimetic design and this new valve? And it could be good or bad. I mean, we're very open about talking about these things.
Maybe I'll answer saying a couple of things. One of them was the ease of use of the valve. It was very easy to implant. It was a balloon expandable valve, so it's not different than what we are already doing. Especially about this valve, what really surprised us was the hemodynamics, because again, especially in the case we showed you today, this was a patient with a very small annulus. Treating this annulus with a balloon expandable valve will result in high gradients already from discharge. And this is not what we saw with this valve. So this was really a positive surprise. And this is giving us hope that this valve might last longer. Clearly, we need data, we need follow-up, we need a paradigm to answer this. But I think this is a good sign, and this was a very good surprise for all of us.
Right. Yeah. I think the other thing that surprised me potentially was, again, we like balloon expandable valves because of their reproducibility of being able to implant it. And I think, that was very good. But I was a little worried initially because I've seen it with other balloon expandable valves trying to do commissural alignment, that as you inflate the balloon unwraps and the valve rotates and you lose that commissural alignment. But I was surprised to see that the engineers have figured out how to do this well, and we're not seeing that rotation, that patients are getting true commissural alignment. So Andrea, thank you so much. Great case. Greg, your insights as always are incredible. I don't know, people didn't know, but you sitting in a scrub cap because you were probably in the hospital all night doing surgery, yet you made time for us this morning. So we're very appreciative. Thank you for being on this, and thank you both for all your insights.
You. It's a pleasure.